Thank you, Binay. Thank you, everyone. So today I'm going to focus my session on two drugs, 5-azacitidine and decitabine, because they're the only two drugs that are FDA approved to treat all subtypes of myelodysplastic syndrome. So I'll begin by going over the reason why they're probably the only two drugs that we have after decades of trying, and what the properties are of these drugs that we should be paying attention to, and how in our clinical application we can perhaps maximize the utility of these properties, and finally why it is that these drugs are not a cure. So as I just said, these are the only two drugs. After several decades of clinical trials in myelodysplastic syndrome that have evaluated several agents, this is just a subset. These are the only two drugs. So what is it about these two drugs compared to all of these other drugs that allowed them to succeed, and these other agents have had limited activity? So obviously this list shows that these different drugs have different molecular targets, and we're not learning a lot from looking at this. What about commonalities? Are there things that are similar between these agents that would explain why they didn't work? Well, let's look at this last column here. They all, at the end of the day, intend the same phenotypic consequence. They're trying to induce cell cycle exits by apoptosis in cancer cells. This cell cycle exit by apoptosis, that's a master program that involves the regulation of hundreds of genes. It's regulated by master transcription factor. That master transcription factor is p53, and it's worth thinking a little bit about p53. So a cell, in the day-to-day, a cell is going to sustain a range of stressors, wrong place, damage to the membrane, damage to the DNA. All these various inputs, all these different kinds of stress converge onto p53 as a master switch. Those different drugs that we've been evaluating, DNA damaging agents, antimetabolites, anti-cytoskeleton, kinase inhibitors, et cetera, proteasome inhibitors, they're all different inputs mimicking those physiologic stressors that a cell might encounter, but they still converge onto the same master switch, p53. Now, a cancer cell, in its natural evolution, is going to try and avoid the cell cycle exits imposed by this stress, because by its very nature of being a malignant cell, it is going to encounter stress. And so the most efficient strategy for avoiding that stress is to get rid of the master switch. So these various inputs converge onto p53, which generates the range of outputs that collectively we call apoptosis, and cancer cells get rid of p53, including frequently malignant myeloid cells, and this is a way for them to avoid stress, but it's also a way that they avoid our drugs. So what does this mean in terms of our therapy, if our therapy is intending apoptosis? It means that yes, we might get some mileage, we might get a temporary response, we might get some temporary cytoreduction, but we will select for the most apoptosis, the most p53 null malignant clone. And this clone is now going to be resistant to our second and our third line of therapy somehow, even though it's never seen those agents, because even though those agents may be different drugs, they are intending that same phenotypic consequence, that same p53 dependent process, which the cancer clone has already learned how to evade. And in the meantime, all those normal dividing cells with intact p53 are being destroyed. Okay, so this is our daily clinical experience. Every single one of us in this room knows this from our clinical practice on a daily basis. So, and this clinical reality can be codified actually in the data. When we look at the myelodysplastic syndromes or the acute myeloid leukemias that have the worst outcomes, they're the ones which are p53 null. And in fact, if we try and correlate p53 status to response, we again see that being p53 mutated or having a mutation disabling event in the p53 system correlates with very poor outcomes with standard cytotoxic intending treatments. And perhaps the most dramatic illustration of this is to look at the cancers that we cure versus we don't cure. Testicular cancer, essentially the only adult solid tumor malignancy that we cure when it's unresectable. The reason we cure it is because it's p53 null. If we have a case of testicular cancer that has a p53 mutation, it's no longer curable. Same goes for pediatric ALL, and all those notoriously incurable malignancies are the ones with the highest rates of p53 system inactivating alterations. So if we're going to make progress in diseases like myelodysplastic syndrome, where it's even more critical that we have a good therapeutic index, our patients with myelodysplastic syndrome, they're dying because of low blood counts. We cannot afford to be killing the normal cells with intact p53. Therapeutic index is especially essential when we're treating myelodysplastic syndromes. We need not just new drugs, but they can't be depending on p53 for the final pathway for irreversible cell cycle exit of the malignant clone. And so is there another way? Yes, there is. There's differentiation. p53 null mice and the other partner protein for p53, p16 null mice actually exists. p16 null mice exist. They're normal mice. They run around, they mate, and that's because cell cycle exits by differentiation do not require p53. And for several decades, it's been a scientific observation that we can take cancer cells, essentially any cancer cell. It can be a melanoma, lung cancer, certainly leukemia stem cells, leukemia cell lines, and if we expose them to conditions that relax the chromatin, basically conditions that inhibit the enzymes that turn genes off, we find that they terminally differentiate. Whether or not they have p53 or p16, they will cell cycle exit by differentiation. So why is this? Well, if we actually examine myeloid leukemia stem cells, the so-called leukemia stem cell or leukemia initiating cell or the MDS stem cell, the cell that if you put it into a mouse, immune compromised mouse, will initiate myelodysplastic syndrome or myeloid leukemia, you will find that actually they express very high levels of the master transcription factors that make a lineage. So an AML stem cell or a myelodysplastic syndrome stem cell is not expressing stem cell master transcription factors, it's expressing the master transcription factors that would usually make a monocyte or granulocyte. Yet clearly that intended lineage fate program is being inefficiently executed, if at all. And the reason for that is that if we look at the genomic landscape of a malignancy, we will find that there are inactivating alterations in the enzymes, the epigenetic enzymes, that these transcription factors use to turn on the hundreds of genes that it takes to make a granulocyte or monocyte. Or they will mutate or delete the cofactor that the master transcription factor uses to resolve the balance between the enzymes that turn genes off versus the enzymes that turns gene on. So in a normal developing hematopoietic precursor, these transcription factors are recruiting the machinery that turns genes on. But what happens in malignancy is that because of a mutation, let's say in RUNX1, or a deletion event of one of those on enzymes like SMARCA-D1 or something, you are now getting, even though you have that master transcription factor that usually activates these genes are being turned off. The enzymes that turn it off instead of on are being recruited. These are enzymes and they are druggable. And so if we drug those enzymes with drugs like decitabine or 5-azacitidine, we shift the balance back to the on enzymes and we can turn on those hundreds of differentiation genes and we will get terminal differentiation of that cancer cell. And meanwhile, if we inhibit those off enzymes without anti-metabolite effects in a normal dividing cell, basically it just does what it was going to do anyway. So if it was supposed to make stem cells, it will just make stem cells. If its master transcription factors were telling it to make a granulocyte, it will make granulocytes. So this is not conjecture. There are actually several hundred publications showing this kind of science. And certainly, preclinically, it has an excellent therapeutic index. You can stop the malignant cell from growing even if it does not have p53 while sparing normal dividing cells. And this is just to show you it's not a cartoon. So we can actually identify those on enzymes and those off enzymes. And amongst those off enzymes that are recruited to a master transcription factor like Q.1, when RUNX1 is gone, is the enzyme DNA methyltransferase 1. So that's a major off enzyme. And if we deplete that off enzyme from a leukemia cell, so this is a MLL AF9 leukemia cell, what we end up doing is turning on differentiation genes, including bona fide antagonists of MYC, which will induce cell cycle exits via P27, even though these leukemia cells don't have P53 or P16. And Ara-C doesn't do anything. It doesn't turn on these differentiation genes, and these cells are resistant to Ara-C, just like they are in the clinic. So we actually have the drugs to translate this science, and that's what 5-azacitidine and decitabine are. So let's take a closer look at these drugs, because this chemistry of these agents plays a critical role in whether or not they're going to work in the clinic. So this is the C that goes into our DNA, and the only difference between this C and the drug decitabine is a carbon in the pyrimidine ring is converted to a nitrogen. The sugar in decitabine is physiologic. The only difference between decitabine and 5-azacitidine is that 5-azacitidine is a ribose and decitabine is a deoxyribose. The fact that the sugar is physiologic is very important. This is how these agents differ again from other drugs, other nucleoside analog drugs like cytarabine and fludarabine, et cetera, where the sugar is modified, and the intent is for when the agent enters the DNA during S phase to terminate DNA chain elongation. These drugs, because they are almost like a natural product, they're almost like the C that goes into our DNA, are rapidly metabolized by endogenous pyrimidine metabolism enzyme systems, such as cytidine deaminase, which deaminase these drugs to uridine counterparts within minutes. So in vitro, the half-life is about 12 hours, but if I was to push this into my vein, it would be gone in about 5 minutes because of this enzyme, cytidine deaminase. So if we can get past cytidine deaminase, it enters the cells, and then it gets phosphorylated. In the case of decitabine, because it's a deoxy, it's phosphorylated by DCK. In the case of 5-azacitidine, it's phosphorylated by UCK. Once it's got the phosphate group, it's stuck in the cell. It's a large negative group. It can't leave. So the intracellular half-life is much longer than the plasma half-lives. Once it's diphosphorylated, about 10% of 5-azacitidine gets converted to decitabine. So that is why, if you look at what we do in the lab, we will generally use about 10 times the dose of 5-azacitidine than we use of decitabine, because it's only 10% of 5-azacitidine which becomes decitabine, which then enters the DNA during S phase, and when DNA methyltransferase comes along and tries to methylate what it thinks is a C in that pyrimidine ring after replication fork, it is covalently bound. That complex gets degraded out. And so it's not just an inhibition of DNA methyltransferase activity, we're actually depleting the whole protein. So these drugs are often referred to as hypomethylating agents. They're much more than that. They're actually removing this whole very large platform protein upon which other epigenetic enzymes aggregate. So you end up with a very profound epigenetic therapeutic effect, which very profoundly disrupts that network of off enzymes. So let's examine what this means for us in the clinic a little bit more. So with cytarabine, the goal when we give it to a patient is to damage DNA. So that is our intended molecular pharmacodynamic effect. Obviously that's going to occur also in normal cells, so the therapeutic index is very narrow. Sometimes we have a patient with comorbidities or is old or something like that, and we say, hey, you know what, they're not going to be able to withstand the toxicities, I'm going to reduce the dose. Now, because of our knowledge and our training, we understand that when we reduce the dose to increase safety, the trade-off is less efficacy, because the pharmacodynamic effect is so clearly related to dose. But that's the trade-off we make in the clinic. This sort of thinking does not apply to decitabine and 5-azacitidine. So, and that is because the sugar is physiologic. So the DNA damage curve is shifted to the right relative to cytarabine. And at low doses, that's how you get the DNMT1 depleting effect. And it is very important that when we use these drugs, that we try and use them within this green zone. And that is because the epigenetic therapeutic effect, the reason these drugs have succeeded, they're P53 independent, normal, the good therapeutic index mechanism of action is in this green zone. And if we stray into the red zone, that toxicity, that off-target toxicity, then limits how often we can give the drug, which then limits how much we can get of that good therapeutic effect. The reason that these drugs have succeeded where all those other drugs have failed. And this is the lesson of history. So when these drugs were first developed, they were developed like chemotherapy for off-target anti-metabolite cytotoxic effects. So they maxed out to the maximum tolerated dose. Because of those toxicities, then patients weren't treated for several weeks, and they just didn't work. And purely by empiricism, by trial and error, the doses were reduced, they were given more often, culminating in the extremely well-tolerated regimen that we use today of 5-azacitidine. It's essentially a non-cytotoxic, pure epigenetic regimen. Nonetheless, if you look at the literature, if you look at academia, there's still a lot of argument. Hey, we don't know how these drugs work, and that kind of argument resulted in decitabine also being tested in the traditional, conventional way. And these are the two FDA-approved regimens of decitabine. This was the first one. When they reduced the dose and gave it more often, they doubled or tripled the response rate. And what we did is we did a clinical trial where we explicitly dosed it only in the green zone. And by doing that, we were able to give it 2 to 3 times a week. And in an NIH-sponsored clinical trial, we were able to treat very sick patients, including patients who had progressed through 5-azacitidine, and we showed that this regimen was not cytotoxic at all. This is the bone marrow. This is a stain for bone marrow damage, and there was no bone marrow damage in responders or non-responders between pre-treatment and after 6 weeks. And we looked to confirm that there was the epigenetic therapeutic effect. So DNMT1 decreased between 0 and 6 weeks in both responders and non-responders. And MYC, the master transcription factor regulator, the master oncoprotein driver of cell growth and division, it went down, and P27 went up in the responders. So, and in terms of the clinical responses, they were very, very good and very, very durable. And so one patient actually is still on therapy 6 years out. She was 84 when she started. She's now 90. And she's continuing to be platelet transfusion independent, no toxicities, no antiemetics. So this science does translate. And really the reason that we did this trial was to prove the point that the way these drugs work is by their epigenetic therapeutic effect, not by cytotoxicity. It's not cytarabine, it's an epigenetic drug. And we get complete cytogenetic remissions, even in cases that were p53 null. So this patient had a 17p deletion and a mutation, inactivating mutation of the remaining p53 allele, complex cytogenetics. She was also 84, and she had a very durable remission lasting some years. So in terms of concept, this is worth dwelling on a little bit more. Let's imagine when we have a patient showing up in front of us in the clinic, what's going on. So on the x-axis over here, we have the number of doubling times of their malignant clone, and on the y-axis, we have the tumor burden. So that malignant clone that has culminated in them showing up in our clinic with low blood counts was growing over several years. And it's between 10 to the 11 to 10 to the 12 cells. Now, traditionally, the convention when we confront a myeloid malignancy is we use induction chemotherapy. And the goal with induction chemotherapy and consolidation chemotherapy is to produce a multi-log reduction in their tumor burden. And the rationale for that was that the goal was cure. And the trade-off is that there's a lot of toxicity. Patients in the hospital for 6 weeks or 8 weeks, or they die in the hospital because of prolonged marrow-aplasia, because of course, that approach, you're killing good guys. You're not just killing bad guys, you're also killing good guys, and there's no guarantee that there's going to be any good guys that are going to come back. Now, this sort of risk, this sort of trade-off makes sense when the intent is cure, when there's a reasonable possibility of cure. When we know that where the reason we're treating is palliation, is to make the blood counts better, this sort of thinking does not necessarily apply. So when we use 5-azacitidine and decitabine, we're not trying to produce a multi-log kill. We're not shooting for cure. We just want to push that malignant clone burden back to before the time where it tipped over to the point where the patient had cytopenias. That clone was there for years and years, and nobody knew and nobody cared. We don't need to go back all the way to 10 years ago. We just need to go back to 1 year ago when their blood counts were normal. And that's all we're trying to do with the 5-azacitidine and decitabine. And the trade-off is no toxicity, very low risk of treatment-related mortality, and this is shown in the data. So even in cases of AML. So this is a randomized controlled clinical trial of technically AML with 20 to 30% myeloblasts, and you can see azacitidine was better than competing regimens which included induction chemotherapy or low-dose cytarabine. And this is more aggressive AMLs, greater than 30% myeloblasts. And again, azacitidine, by that regimen that we just looked at, a non-cytotoxic, very well-tolerated regimen, comes out ahead. So if the patient in front of you, you know that the chance of cure is zilch because of their age, because of the complex cytogenetics, et cetera, we really should be thinking of these agents in the first line. Also because of their distinct mechanism of action compared to cytarabine and daunorubicin, we can use these agents to salvage chemo-refractory cases. This is in the literature, and I'm just showing you an example from my own clinic. This is a patient, again, he was 84 when he saw me, and he first had a response to low-dose Ara-C, became transfusion independent. He relapsed. More low-dose Ara-C was tried by his physicians. Then he relapsed again, tumor lysis. He was sent to hospice, but he came to see me, and I used sub-Q 5-AZA and DEC and gave him almost 3 years of excellent quality of life at home, not in the hospital. So to sum up, really when we use these agents, we're using them not for cure, and I'm going to, if I have time, I will touch upon why they are not a cure, but they can certainly improve both quality and quantity of life if we use them the right way. But relapse is inevitable. So the good thing about trying to understand why relapse occurs is that we do know what our intended molecular pharmacodynamic objective is. It's to deplete DNMT1. And when we actually examine patients at the time of relapse, we find that it is not by malignant cells that are growing despite depletion of DNMT1. So it's not that we are achieving our intended therapeutic effect and the cancer cell doesn't care, flips off the bird and keeps on going. It's that we are not achieving our intended molecular pharmacodynamic effect. So why not? So remember that that epigenetic therapeutic effect is S-phase dependent. So obviously we have some control over that with how often we give the drug, etc. But there's also this pyrimidine metabolism factors. And there are 3 key enzymes involved in these drugs. There's cytidine deaminase, which very rapidly inactivates them. There's DCK, which dictates the intracellular half-life of decitabine, and UCK2, which dictates the intracellular half-life of 5-azacitidine. And cancer cells, in fact, all cells are flexible. These are metabolic enzymes that cells use if and when they need them. And when we look at leukemia cells, some are using more DCK and less UCK2, and some are using more UCK2 and less DCK. And in fact, when we look at patients on decitabine at the time of relapse, and we measure these enzymes in their cancer bone marrow cells at the time of relapse, in patients on decitabine, they have downregulated. We have selected for a clone that has shifted to salvaging C in the form of RNA using UCK2. And it's also, in the case of decitabine, which is being given at lower doses than 5-AZA, we also select for malignant cells that upregulate cytidine deaminase. And exactly the opposite is happening with 5-AZA. So it's that simple. Resistance to these agents is that simple. And cytidine deaminase is also a pharmacogenomic factor. So in this room, some of us are expressing more cytidine deaminase in our livers than others, and that will also influence the activity of these drugs. And very often, just to expand and underscore this point, I sometimes see patients where they're labeled as being resistant to decitabine or 5-azacitidine. But if you actually see how often they were getting the drug, they were getting it maybe 3 times a month. So that's not really resistance. It's not cells that are seeing 5-AZA or decitabine and growing through it. It's cells that are growing in all those days that they are not seeing 5-AZA or decitabine. And all you have to do perhaps is increase the frequency at which you give these drugs and you will get a remission. And another conceptual error that's sometimes made is to think that less aggressive disease, maybe I can treat them less often. So, hey, you know, it's low-risk MDS, there's no blast, I'm just going to give the drug 3 times a month. But if it's less aggressive disease with a smaller S-phase fraction, paradoxically, or counterintuitively perhaps, you actually need longer exposure to produce the same fractional kill than with a high S-phase fraction disease. And the clinical trials have actually been done that showed this. So MD Anderson did a randomized controlled clinical trial of giving decitabine less often in the best possible patients, low-risk patients who were completely treatment naive. And the response rate was less than half that they had seen in the same center with 5 days of administration. So I'm just going to skip this. Okay, so bottom line is that resistance is, we can actually understand resistance. The molecular target is great. These cancer cells truly have a non-oncogene addiction to this enzyme system to prevent cell cycle exits by differentiation. So when we get resistance, when the molecular target is so good, your resistance is by preventing you from hitting that molecular target, to some extent, like we see with BCR-ABL in CML. And we can understand this, and we can actually address this. So this is mouse data, and by combining the cytidine with an inhibitor of cytidine deaminase, we can produce almost 9 months of survival in a mouse model of leukemia. And by alternating the cytidine and 5-azacitidine with that inhibitor, we can produce survival of these mice for almost a year. And they do eventually relapse, and this is non-cytotoxic, as you can see from the blood counts. And eventually they do relapse, but even here, when they relapse, it's because of pyrimidine metabolism. So again, it's because we are no longer hitting DNMT1, and we selected for a clone that highly upregulates cytidine deaminase so that it dwarfs the amount of the inhibitor that we're giving, and the cells have shifted to de novo pyrimidine synthesis. So we're exploring the addition of a de novo pyrimidine synthesis inhibitor. So this is my last slide. So the last fundamental problem when we're treating a myelodysplastic syndrome as opposed to a prostate cancer is that it's not so much about getting rid of bad guys. Actually, the problem is that we need good guys to come back. And sometimes because of the age of the patient, because of previous chemotherapy for their breast cancer or their Hodgkin's, they just don't have a lot of, because of their smoking history, or maybe because they had a previous aplastic anemia, they just don't have a lot of the good stem cells needed to come back and make the blood cells they need to recover their blood counts. In that sort of scenario, decitabine and 5-azacitidine is not going to fix it. We need other solutions, and it's possible that we do have those solutions. Drugs like L-Thrombopag that can promote functional hematopoiesis. So I think there is some hope on the horizon, and I'll just skip that. Thank you very much.